Uh, Welcome to this webinar on adult ADHD in Scotland, presented by members of the Royal College Working Group. The purpose of the webinar is to promote thinking on the development of an adult ADHD pathway. The speakers today are all members of the Royal College Working Group in adult ADHD, and the areas we're covering are the background to adult ADHD in Scotland, presented by Ishbel McIver, structuring services for adult ADHD in Scotland by myself, Marie Boilson, adult ADHD in prison settings by Sheila Howitt, and adult ADHD and a digital approach by Prem Shah. So our first speaker today is Ishbel McIver, who's a recently retired general adult psychiatrist who's had a long-standing special interest in adult ADHD and started work on pathway development in Greater Glasgow and Clyde. So I'll hand you over to Ishbel McIver just now.
Thank you, Marie. So my goal today is just to say a little bit about ADHD, to describe briefly what it is, but to speak a little bit more about how it affects people, and then briefly to look at the situation in Scotland in terms of where we are in managing this. So first of all, what is ADHD? And why is it so important to diagnose and treat? Particularly just now, I think that's a question we need to answer, given how difficult things have been in the NHS over the last year. A lot of people are asking why we still need to focus on something like ADHD, and I hope I can convince you that that is still necessary just now. So ADHD is attention deficit hyperactivity disorder. It's a neurodevelopmental disorder characterised by problems with inattention, hyperactivity and impulsivity. These traits typically emerge in childhood, but can persist throughout the lifespan, and contrary to what some people say, it doesn't simply go away at the age of 18. And studies have shown that up to 2/3 of children can go on to have significant symptoms as adults with associated impairment in functioning. The second important thing about ADHD is that it's a trait-based disorder, and these traits are on a continuum. So as anyone who's ever filled in an ADHD screening questionnaire will know, we all have these traits to a greater or lesser degree. And it's important to say that for some people, these traits can confer an advantage. But what makes this a disorder? Well, I guess on one hand, it's the severity and the frequency and the clustering of these traits, but most importantly, as for any other mental health disorder, what makes ADHD a disorder is the impairment in functioning that's associated with that. So how common is ADHD? Well, it's actually a relatively common disorder. Prevalence rates are quite difficult to establish precisely, although there has been a lot of work done on this across the world. And I guess the differences probably reflect different thresholds for diagnosis and treatment in different countries, and also the different healthcare systems in different areas of the world. But the worldwide prevalence rates for children are thought to be between 2 and 5%, and for adults between 2 and 4%. You can see that for children in Scotland, we are diagnosing and treating fewer children than one would expect in terms of these prevalence rates. And I will come back to the prevalence rates for adults in Scotland at the end of this presentation. A couple of other important things to say about ADHD is that it runs in families. There is a huge genetic component to this. Twin studies show 70 to 80% concordance, and sibling concordances are between 15 and 47%. So where that's important in clinical practice is that if you are seeing an adult with ADHD, there's more than a 50% chance that one of that person's children will also have the disorder. And conversely, if you're treating a child with ADHD, there's a 15 to 40% chance that one of their parents will also have this. So that's important to consider when you think of the impact of ADHD on a family. Next thing to look at is the gender disparity. ADHD is very much a disorder which affects boys more than girls, particularly in childhood, although this gender difference tends to even up a bit into adulthood. And that may be partly related to the fact that boys tend to experience more of the hyperactive impulsive features of ADHD, while girls tend to experience more of the inattentive symptoms. And if you think about it, little boys with ADHD can be quite disruptive and do get noticed in school and at home, and probably are more likely to be diagnosed than little girls with ADHD, who may present as being quite dreamy or in a world of their own. But this inattention can be quite limiting and quite impairing, and can, we think, also possibly contribute to the development of other anxiety or depressive disorders which are more prevalent in females in later life. So looking at the DSM criteria, diagnostic criteria for ADHD, just to mention very briefly, ICD-10, which is a classification system that we normally use within the UK, talks about hyperkinetic disorder rather than ADHD. Hyperkinetic disorder describes a very strictly defined subgroup of ADHD who are particularly impaired. By convention across the world, we do tend to use the DSM criteria for diagnosis of ADHD, even in the UK. So for diagnosis of ADHD, you need core symptoms of inattention, hyperactivity and impulsivity. Crucially, the onset has to be before the age of 12 years and has to be associated with impairment in 2 or more settings, and obviously not secondary to another disorder. So these are the DSM-5 diagnostic criteria for adult ADHD, and you can see that these fall into two groups. On the left of the screen we have the inattentive symptoms, and on the right the hyperactive impulsive symptoms. So for a diagnosis of ADHD in adults, you would need to have 5 out of the 9 inattentive symptoms and or 5 out of the 9 hyperactive impulsive symptoms. You can have an inattentive subtype or hyperactive impulsive subtype, but more common is the combined subtype where you have 5 out of the 9 in each of these 2 columns. I'm not going to go through them individually just now, as most people will be quite familiar with these. It is important to think about how ADHD can change in terms of how it presents in adults. So the hyperactivity that you see in children can change into adulthood. For example, you're not going to see an adult with ADHD running around the room or climbing on the furniture. What you're more likely to see is restlessness, fidgeting, or the person making excuses to move around or leave the room, for example, having to take toilet breaks, or examples in their everyday life of completely avoiding any situation where they have to be still for long periods. The physical impulsivity that you see in children can persist in some adults, for example, doing things without thinking of the consequences, but very often what becomes more typical is verbal impulsivity. So for example, talking out of turn, blurting things out without thinking, or talking over other people. And sometimes people with ADHD can come across as quite tactless because they speak before they think. And this can cause a lot of problems with relationships. The thing that really doesn't change much as we move from children into adults is inattention. And in adults, inattention really can predominate in terms of the clinical picture. Other features of ADHD in adults which are worthy of comment are sleep problems, which are very common, mood instability. Patients often describe ceaseless mental activity, and we often see anger management problems as well. I'm just going to say a little bit about mood instability because this is very, very common in adults with ADHD, and in one study was shown to affect over 90% of people in adulthood who presented with ADHD. What that looks like clinically, what you tend to see is a picture of rapidly fluctuating mood states over the course of a few hours or days, very like the picture we see more typically in emotionally unstable personality disorder, and that can lead to diagnostic confusion. But where it's also relevant clinically is where you might have a patient with AUPD who maybe presents atypically. It is always worth asking yourself, is there a possibility that they may have ADHD, because treating the ADHD can sometimes have quite a significant impact on the other features of the AUPD which may be present. So this slide looks quite simple, but actually is probably one of the most important ones that I'll show you today, and talks about the cost of untreated ADHD. What happens if we don't treat people for ADHD, and why is this really important for us to be looking at, particularly, as I said, this year when we're so worried about COVID and there's so much pressure on services. So what I'm going to do is talk you around this slide, starting in the top left-hand corner and talking around the screen, and I'm just going to list all the ways in which ADHD has been shown to affect people. So while I'm doing so, I want you to think about this in terms of the impact on the individual, but also on families and on society as a whole. So starting from the top left-hand corner, people with ADHD have much lower educational performance than others and are more likely to drop out of education. When you think of the societal costs of this, you can add into that truancy, delinquency, and the cost of teenage pregnancy. And this in turn can lead to difficulty sustaining employment. People with ADHD get fired a lot or walk out of jobs, and often have worked in a lot of different jobs over many years or have become unemployed. People with ADHD are more likely to experience relationship difficulties. They have fewer close friends and have higher rates of family breakdown. Interestingly, they also have increased rates of partner violence. People with ADHD are more likely to experience financial difficulties or problems with gambling and problematic internet use. They are 2 to 3 times more likely to misuse alcohol or other substances, and they tend to start smoking and using these substances at an earlier age than others. People with ADHD are more likely to be obese and are likely to have at least one other comorbid medical diagnosis. Medical problems may be induced by an unhealthy lifestyle or associated with poor eating and sleeping habits. And perhaps due to forgetfulness and disorganisation that is inherent amongst people with ADHD, they're less likely to attend for things like screening appointments or to engage productively with health services in general. People with ADHD are also 4 times more likely to be victims of accidents than the general population, either at home, and where this is particularly relevant is in terms of road traffic accidents. They're also more likely to have experienced childhood abuse. People with ADHD are 3 to 7 times more likely than others to have another comorbid psychiatric disorder, and in adults, more than 50% of people have at least one other comorbid psychiatric disorder. People with ADHD are 2 to 3 times more likely to be arrested or to be convicted or end up in prison, and we're going to hear a little bit more about this later on from Sheila. And finally, I want to just think about parenting. There are some aspects of ADHD which can make parenting very difficult, and although many patients with ADHD make lovely, wonderful parents, I want you just to think about the impact of all of the above things that I've talked about on a child living in a family where one or even both parents may have untreated ADHD. Bear in mind also, given the heritability of the condition, that one or more children in the family could also have ADHD. So it is important to think about the needs of any children who are being brought up in a family where untreated ADHD is present. So just moving on briefly to talk a little bit more about psychiatric comorbidity in adults with ADHD. As I said, people with ADHD are 3 to 7 times as likely to have a comorbid psychiatric disorder as the general population. And this generally takes the form of mood disorders, with a 38% prevalence of any mood disorder and a 47% prevalence of any anxiety disorder. There are also higher rates of comorbid personality disorder, and other neurodevelopmental disorders are also common. For example, there's a 30 to 40% prevalence of comorbid ASD. So I also just want to mention in a little bit more detail comorbidity with alcohol and substance misuse, which is significant in adults with ADHD. As I said, they tend to start using substances at a younger age. The reasons for this problematic use, there are several postulated reasons for that, which are fairly self-explanatory. But what's important to remember is that actually treatment for ADHD can reduce this substance misuse. And although we don't necessarily want to be medicating people with very chaotic, dangerous substance misuse, it can be worth liaising with addiction services for people if they can get their addiction issues under some control. Treating the ADHD can be very effective in improving their welfare in general and hopefully reducing their reliance on substances in the longer term. So this slide looks at the impact of ADHD on functioning from a developmental perspective, and I've included it really just to show the trajectory of a person's life, really, in terms of what happens to someone with ADHD who doesn't get picked up at an early stage. Very often the patients I've seen presenting as adults with ADHD will describe problems dating right back to their preschool years. For example, many describe having been excluded from nursery school, which always makes me think that there's something far wrong, either something wrong with the child or something far wrong with the environment the child is living in at that time, and it's a real red flag in terms of neurodevelopmental disorders in particular. The reason for including this slide really is for us to think about what could happen if we could interrupt this trajectory, ideally at the early stages in a person's life, but also even in the teenage years or into adulthood. What can happen if we can interrupt this? What impact could that have on people's functioning and the cost of ADHD, as we talked about before? So the good news is that ADHD is actually very treatable. And obviously within the UK, the reference point for the treatment of ADHD is the NICE guideline, NICE guideline 87, which was very helpfully reviewed last year. I've included another couple of references here which are really worth a read in terms of particularly the drug treatment for ADHD, and that's the British Association of Psychopharmacology guidelines for treatment of ADHD, and the European Consensus Statement, which was also recently updated. Gives some very helpful information, gives a lot of information about the evidence base for treating ADHD, particularly with medication, and gives very clear guidance on the treatments that are recommended, particularly within Europe and the UK. So looking at the NICE guidelines, first of all, NICE guidelines recommend medication as first line for treatment of ADHD in adults, and the evidence base for medication is really very robust. There are multiple studies across the world and in the UK evidencing particularly stimulants and atomoxetine as first-line treatment for ADHD in adults. From these studies, it's worth noting that the number needed to treat for stimulants such as methylphenidate and lisdexamfetamine is around about 3, and for atomoxetine is 4. And these are significantly better than the NNTs for any other treatment that we have in psychiatry. So as I said, the evidence for treatment with medication is robust. Crucially though, treatment doesn't just impact on symptoms, because as I said before, people can have a whole cluster of ADHD symptoms which can in themselves be quite severe, but unless these are associated with significant impairment in functioning, then it isn't really a disorder. So any treatment that we offer for the symptoms of ADHD has to have an impact on the impairment in functioning for it to be of any use whatsoever. And this study by Shaw et al. Very helpfully looks at the different outcome groups, as I talked about earlier, and looks at the impact of treatment on these, and very helpfully shows that treatment for ADHD can impact very significantly on each of these outcomes. So even more importantly, how does this translate into real life clinical practice? Well, having treated fairly large numbers of adults with ADHD over the last 10 years or so, I can honestly say that it really does make a difference to people's lives and their families, and impacts on all of the outcomes that I talked about early on. So it is, in the patients I've seen, it has made a big difference to their lives. Just going back to the NICE guidelines again, it isn't just about pills, and the NICE guidelines do talk about psychological approaches to treatment, and although these are not as robustly evidence-based as medication, there is a recommendation that, you know, even before we think about medication, we do have to think about the environment in which a person lives and functions. And even before we start medication, we have to consider whether there are any environmental modifications which can be done simply or alongside medication. Thinking about non-pharmacological treatments, NICE recommends these for adults who have either chosen not to take medication or can't take medication for one reason or another. And they advise combining psychological treatments with medication for people who have had a partial response to medication, but who continue to have symptoms with some impairment despite this. Again, relating this to clinical practice, what I have often seen with my patients are people who, particularly one group of patients who have significant comorbidity with, say, anxiety, depressive disorders, or people with complex PTSD associated with perhaps features of EUPD, and past history of trauma. People with comorbid ADHD really find it difficult, if not impossible, to engage with psychological treatments for these comorbid disorders if their ADHD is untreated. What I've actually found in practice is that treating the ADHD with medication can enable these people to engage, often for the first time, with the psychological therapies that they need. And that has been quite enlightening for me in terms of the benefits for patients of a combined approach. There are also non-pharmacological treatments for ADHD symptoms in themselves, often considering CBT models of treatment. Mindfulness has an evidence base for treatment of ADHD, and you know, all of these are worth considering for people with minimal benefit from medication or who can't take medication. So just thinking now about how things are in Scotland in terms of adults with ADHD. Well, this has really come onto the agenda probably in the last 10 years in Scotland. Health Improvement Scotland did a survey back in 2012, which they published, which really showed a significant underdiagnosis of ADHD in children across the country, with diagnostic rates at that time of 0.6%. And again, if you think about the prevalence of ADHD in children in the UK being between 2 and 5%, you know, that really is quite low. They also found, as we might expect, a real dearth of services, particularly for adults with ADHD. Since then, things have come on a bit, but services for ADHD have developed across the country in a fairly ad hoc manner, and things are at very different stages in different health board areas. A group of us have been working together under the auspices of the Royal College of Psychiatrists in Scotland, looking at this over the last few years. And what we've seen are services being developed in areas where you may have a clinician or a few clinicians with a special interest. And what we've been trying to do is make sure that what's been learned in one area is being propagated out to the different health board areas. But until very recently, there hasn't been any kind of overarching framework for this. But as Marie will go on to tell us, there is this is now being looked at by the Scottish Government, which is a very positive step forward, obviously, for us all. So where are we at in terms of adults with ADHD in Scotland? So this slide was very helpfully produced by the Scottish ADHD Coalition and is based on data produced by the ISD, and it looks at the prescribing rates across Scotland in the different health board areas in relation to prescriptions for ADHD medications. So each column represents the percentage of the population aged between 20 and 69 in each health board area who were being prescribed medication for ADHD. It refers to 2016 to 17. Just to mention, the numbers have gone up slightly since then, but not hugely, so these figures are still relevant in 2020. So the column to look at really is the one on the far right in orange. So that gives the overall Scottish percentage of people, of adults prescribed medication for ADHD, which is around 0.09%. So if you think about that, going back again to the prevalence of ADHD in the population, if we go for a figure across the UK of 2.5%, and we think that in Scotland we are treating 0.9%, just to put that into context, for every one person that we are treating for ADHD as an adult in Scotland at the moment, there are another 24 people going around with untreated ADHD. That translates into around 75,000 adults in Scotland with untreated ADHD. This is what 75,000 people look like. And to put that into some kind of Scottish context, I'm told that that's slightly more than the full capacity of Murrayfield Stadium. So all these people in Scotland currently with a diagnosis of ADHD who are not receiving treatment. So I just want to leave you with that and ask you to think about the cost of that to the individual in terms of what we've already spoken about, and to their families, and to us all, and to society in general in Scotland if we continue not to treat these people. So to summarise, my take-home message today is that ADHD is a very treatable condition. Untreated, it's associated with very poor long-term outcomes. It's associated with significant medical and psychiatric comorbidity and high rates of alcohol and substance misuse. And this impacts, as I said, not just on the individual, but on families and society as a whole. And again, just to remember that for every person that we're currently treating with ADHD in Scotland, there are another 24 people out there with untreated ADHD. So thank you for listening, and I'm going to pass you on to Marie, who will talk a little bit more about assessment for ADHD in adults and about services. Thanks for listening.
Hello, so I'm Marie Boilson, and I'm a consultant psychiatrist and clinical director in Fife, as well as having a session a week with the National Autism Implementation Team. So I'm going to give an outline of work that is ongoing, developing a pathway for adult ADHD in Scotland. So the first step when considering how a service might be delivered is to identify the reference documents which outline the values and principles to be adhered to in that setting. So for us here in Scotland, we have the National Clinical Strategy for Scotland, the Mental Health Strategy, and the Principles of Realistic Medicine. The National Clinical Strategy for Scotland sets out how NHS Scotland needs to change to ensure how health and social care services would be fit for the future. So this strategy is underpinned by the key principles of quality, patient safety, and taking a person-centred approach. Our National Mental Health Strategy for Scotland commits to work to improve in the 4 key areas of prevention and early intervention, access to treatment and joined up accessible services, physical health care, rights, information use and planning. And Realistic Medicine commits to people using healthcare services and their families to feel empowered to discuss their treatment fully, including the possibility of side effects and negative outcomes, and that all decisions about care should be made jointly. This is particularly pertinent to ADHD, as personal agency is central to the management of ADHD in adults. So these commitments lay out how the supporting principles might assist with the development of a pathway, and the next step is to start getting organised to develop that pathway. In January 2020, the Cabinet Secretary for Health and Sport requested the build of a national pathway for managing adults with ADHD, acknowledging that there would be a need for local variation within health boards. As a consequence of this, feasibility meetings have started with various health boards looking at a draft pathway that has been put together, with the aim being to co-construct this across different disciplines over the forthcoming months. All discussions about pathways will need to have resourcing considered within that, as no pathway will be feasible without adequate resources. And then 2020 really took swing in March, which brings us on to the question of, is ADHD a priority now? Well, we would argue that yes, it is, as a third wave of demand on mental health services has been described, and I think most mental health services across Scotland would say that they are actually experiencing this just now. With a period of increased demand on services, there's a need for optimal organisation to be in place. We know that ADHD is associated with increased morbidity and mortality. We also know, as we've heard from Ishbel's talk earlier on, that ADHD is associated with an increase in obesity, and there are implications of an adverse nature for folk with obesity should they contract COVID. Also, ADHD has integral to it problems with disorganisation and disinhibition, and COVID has implications here, as the ability to adhere to social restrictions and infection control requirements can be negatively impacted by problems in these areas. We also have heard from Ishbel's talk how anxiety is present in around 50% of patients with adult ADHD. We also know that the COVID pandemic is associated with generalised anxiety in the population. So there's likely then to be compounded impact on people with anxiety in the context of ADHD, with an increase in distress and morbidity. In addition, the pandemic has brought a loss to a lot of scaffolding which would have supported people previously, such as scaffolding associated with higher education establishments and with occupation or voluntary sector scaffolding. This is also likely to be associated with decompensation for people with difficulties of adult ADHD. The power of mental health services in the NHS is because of its multidisciplinary approach, and delivery of services for ADHD would massively benefit from attention in this area. So based on the Royal College Working Group's guidance document, which is currently being updated, we have put together a draft of a pathway, which is shown in these two slides and which we'll go through in more detail during the rest of the presentation. So within this pathway, we've divided patients into 3 categories. These are adults referred with no previous diagnosis, adults with childhood diagnosis of ADHD being re-referred in adulthood, and transitioning patients from CAMHS and paediatric services. We've further divided the pathway into steps. And this first section here, you've got the steps of pre-referral, referral and assessment. And then we look at what can be in place from the clinical point of view and from the service point of view, and how these might map to the strategic objectives. So if we consider pre-referral and referral as steps at a service level, we know from NICE benchmarking that service can anticipate 25 referrals per 100,000 population per year. As a consequence of this would say that it's quite important to have a transitional protocol in place, and services are asked to strongly consider having this. Patient access policies are important for consistency, but also important that they don't present barriers to care for a condition that has problems with organisation and planning as a core symptom. Managing adults with ADHD, there's a need for prompts and proactive approaches around appointments, and this needs to be built into any service delivery. In addition, providing clinicians with clarity around expectations of NHS services for patients presenting with diagnoses which have been given in the private sector and other countries, which may have different standards and different treatments. And there is, in fact, a national document for Scotland stating that expectation. Ensuring there are systems in place to educate referrers of required information that would support a good referral being in place. Ensuring robust data gathering is in place to provide information for demand capacity planning to future-proof the service. And then if we look at a clinical level, ensuring that referrals provide the relevant information to assist with triage. Here we would emphasise the importance once again of impairment as discussed by Ishbel. So impairment is more important than detailing symptoms, as without evidence of impairment, diagnostic threshold will not be met. Also, the importance of information on developmental history if this was available. As we know from Gilbert's research that contact with professionals such as speech and language therapy, occupational therapy and community paediatrics before the age of 5 is significantly associated with development of neurodevelopmental diagnoses. Provision of information on physical health is also very important. So having template questionnaires that can be sent out on receipt of referral and therefore would be available prior to assessing the patient is very helpful. These questionnaires can be further information on developmental history and questionnaires to support information gathering on the presence of symptoms from a patient and a carer perspective, in addition to the presence of impairment. When we then look at assessment, the service need for training across the MDT is really important. At the clinical level, the importance of a generic assessment using the wider MDT, as we would do for other conditions, can't be de-emphasised. This is particularly in light of the high rate of comorbidities and overlap with other symptoms and other conditions. Were we to go down the route that one professional group was to do all the assessments for any one condition, particularly one with the prevalence that we've heard adult ADHD has, there will invariably be bottlenecks in the system. Clinicians really should also then have subsequent access to templates that might assist with acquiring developmental history or more detailed specific assessments following on from the first generic assessment, such as the ACE Plus or the DIVA. The strategic objectives which are being delivered here are in the areas of prevention and early intervention, though of course the opportunities for early intervention with ADHD have been missed for patients presenting for the first time in adulthood. However, the possibility to prevent the development of comorbid conditions that might develop were the condition not diagnosed and treated are there. Ensuring that there are accessible services is also being met by doing demand capacity planning and having efficient clinical processes in place and systems that are well resourced. In addition, we're also looking at physical health care here. The next steps that we look at in the pathway are diagnosis, treatment and medication. So once again, starting at the service level, ensuring that links are present to third sector employment support and education. Ensuring that there are systems in place to provide post-diagnostic support. Developing shared care protocols for treatment with primary care. Establishing quality indicators and focusing on function and improvement in function, such as using the WHO Disability Assessment Scale or the WEIS Functional Impairment Rating Scale as part of these measures. Involving people with lived experience in looking at quality indicators is very important also. Having in place formulary guidance to assist with medication. At a clinical level, having access to diagnostic criteria available to all clinicians involved in these assessments, having awareness of comorbidities within teams and to look out for symptoms that might suggest the presence of these, being aware of the role of lifestyle advice post-diagnosis, being aware of the significance of environmental modifications as a first step in managing people who do meet criteria for caseness, and then being aware that medication would be the next step should there be ongoing impairment once environmental modifications have been exhausted. The strategic objectives that are delivered here are really met when we consider that recovery and reintegration is the main aim of treatment. Environmental adjustments have a significant positive impact on functioning, and clinicians' ability to support individuals acquire reasonable adjustments to enable them participate fully in education or in employment would be assisting maintain their rights and supporting non-discrimination in education and working environments. We then move on to medication. We break these steps down into pre-screening, titration and monitoring, and then review. At a service level, having systems in place to support physical health monitoring is essential. And being efficient here, auditing this process for assurance. There's huge scope to explore potential for the roles of advanced nurse practitioners in this area, work that has already been done in a lot of children's and CAM services. The importance of developing quality indicators here is key. Having rating scales available, side effect rating scales, and involving, once again, people with lived experience to establish these quality indicators. So we've started the process of building the pathway. Work will continue over the next few months co-constructing this across disciplines, across health boards, and we'd very much welcome any interested individuals being part of that through these regional meetings. Each health board area has a number of individuals who've already stepped forward, but anyone else is more than welcome to join. Our hope is that in the time to come, we'll be able to start to have a more controlled experience for patients, a more consistent approach, and in addition, that clinicians will feel more empowered to deliver good quality care. Thank you. Okay, I'm now going to introduce Sheila Howitt, who's a consultant psychiatrist at the State Hospital and who has done some work at Pullman Prison with young people with ADHD.
Okay. Thank you for that, Marie. I'm Sheila Howitt, consultant forensic psychiatrist working at the State Hospital, and I've got a special interest in adult ADHD in prison settings. So I'm going to take perhaps the next 15 minutes to talk you through ADHD within custody and some of the challenges really in working and diagnosing within this group. So we've heard from Ishbel today about ADHD in the general population and the kind of prevalence rates that we anticipate there will be within Scotland. Now, really, one of the key messages is that the prevalence rates within the criminal justice system are likely to be far higher. It's reported to be between 25 and 45% within the prison population. And thinking back to some of the things that Ishbel talked about in terms of the interpersonal difficulties, in terms of the difficulty in engaging in education, about the high rates of drug and alcohol in this group, and also the rates of criminal behaviours, then it's really not a stretch to think that there might be higher rates in the prison population. And coupling that with the fact that we're probably not picking up a large number of these children with ADHD in Scotland, so again, that there might be an undiagnosed population sitting within the criminal justice system. The next thing to think about is, well, is there any point in treatment in this group? And there's two studies I want to talk through quickly here. The first is Liechtenstein, which was published in 2012, and it was one of these fantastic Scandinavian-style studies using population registers. And what they did was they found 26,000 individuals with a diagnosis of adult ADHD in the Swedish National Register, and then they cross-referenced that with those individuals who had been picking up treatment and picking up prescriptions. And they defined being on treatment as picking up 2 prescriptions for ADHD medication within a 6-month period. And they found that over 2 years, for those that had been picking up prescriptions, there was a 32% reduction in criminality for men and a 41% reduction for women. Now, just to check, were these actually just more pro-social individuals who were linked in with services? They checked for those individuals if they had been picking up SSRI, so antidepressant medication during this time, did that have any effect on their criminality? And they found that it did not. The next study to touch upon is Ginsberg et al., which was again published in 2012, and this was a randomized controlled trial of methylphenidate within actually a prison, and they gave medication to 30 inmates and found that during periods of treatment there was a reduction in symptom severity and improved global functioning. So I think that it really does demonstrate that there are benefits both to the individual in treating these symptoms and also society at large, perhaps in reducing criminality and improving people's functioning. I'm aware that not everyone on the webinar will have experience of how psychiatric clinics work within custody. So in Scotland, the situation is typically that there is a self-referral system. So any prisoner that feels they need to be seen by the mental health team is able to fill out a referral. which then comes to the team. Most commonly would be sleep problems, affective disorders, and a small number may ask to be seen for symptoms of ADHD. These referrals are then triaged by a small team of mental health nurses, and they will see the individual. Sometimes they will offer some interventions, non-medication ones, perhaps for sleep in the first instance. Sometimes there are nurses who are able to prescribe within custody and may instigate some antidepressant medication or similar for individuals. And sometimes people get referred to the psychiatrist. So most prisons will have a visiting psychiatrist. Well, all prisons will have a visiting psychiatrist who will come in somewhere between 2 and 4 sessions a week to see those that have been triaged and deemed to need seen by a psychiatrist in the health centre or in the hall, depending on where the person's able to be brought to. Now, the way that prison clinics run, there's typically quite a narrow window in which individuals can be seen during the prison day, and there can be, so it can be quite a narrow window for seeing people, and there can be further complexities around individuals who are safely able to be in the same place together. Sometimes if a person's being brought from the segregation unit, they will have to take all the other prisoners out of the health centre. So sometimes these clinics can not be terribly efficient. In terms of ADHD diagnosis, most of those would be triaged by the mental health team and then be referred to the psychiatrist for a full assessment. Sometimes some of the prison nurses are experienced in administering screening tools and even doing DIVA assessments, so those can be done before the psychiatrist is asked to see the patient. I would note at the current time that there's very few instances where prisoners are being offered in-person psychiatric assessments, and most assessments by psychiatrists are taking place via near-me technology. The exceptions to that would be if someone is so unwell or psychotically unwell that they don't wish to participate in the near-me video assessment, that the psychiatrist would go in to see them. So to think about our own population in Scotland, in 2014, myself and a team headed up by Professor Lindsay Thompson from the University of Edinburgh went out to the Young Offenders Institute at Polmont, which is the National Young Offenders Unit for Scotland, and we went out with 3 screening tools, and we offered all the young men there the opportunity to complete ADHD screening. We sat down with each of these individuals and went through the screening tests with them. Now, this was partly because we felt that if we just gave the questionnaires out, we might not get many back. And secondly, because there's very low literacy rates within custody. Average reading age is somewhere between 8 and 10 years old. So a lot of the individuals that would have had difficulty with the language in some of these questionnaires. So we sat down with them and read them out to them. So over a 2-day period, we spoke to 300 individuals, and really of note, I would pick up that 25% of these individuals reported a previous diagnosis of ADHD, but only 1 in 8 of those individuals were still on treatment. So somewhere there had been a big drop-off in individuals who had been treated for ADHD in childhood but were still on treatment. And from again back to Ishbel's slides earlier on, we know that actually a lot of the ADHD symptoms will continue into adulthood. When we administered the ADHD screening tools, we found on the ASRS 42% of individuals were screening positive for current symptoms of ADHD, and on the Wender-Utah rating scale, which asks you to think back to your childhood and tries to pick out whether there were ADHD symptoms present then, 66% screened positive. Using the Barclay symptom score, we found 55% were screening positive, so a slightly higher pickup rate there. Now, I'm not saying that all these gentlemen that were picked up on screening would go through to have a full diagnosis of ADHD after full diagnostic assessment, but certainly I think there's an indication there of high ADHD symptomatology within the prison itself. So thinking about how we diagnose ADHD in prisons, I just wanted to really, the process will be the same. Okay, so all the things that Ishbel and Marie have talked about in terms of how we do that assessment are the same for the prison population, but there are some unique challenges which I'm just going to talk through just to highlight the complexities of it in this group. First of all, there's high staff turnover within prison, and there's quite high vacancy rates within the mental health team. So ADHD assessments in some cases are not seen as a priority. There can be quite limited psychiatric provision to the prison environments. The other thing, and this is really once we've given a diagnosis of ADHD, is around how you arrange follow-up for these gentlemen. It can be all very well getting someone set up on medication within custody, but then you've got someone coming up for release who doesn't have a home to go to, who isn't registered with a GP, who may not even have a mobile phone that you can contact them on after release, and it's very difficult to ensure that they leave custody linked into psychiatric services so that they can continue those prescriptions. And actually, if you think about leaving custody, it's quite a danger period for someone being quite vulnerable to returning to substance misuse or other challenges exacerbated by stress. So it's quite an important time to try and make sure that we get it right for continuing of medication. Next, we talk about some of the difficulties with diagnosis. There are high rates of comorbidity in this population, conduct disorder, antisocial personality disorder, high rates of substance misuse. And the other thing is that in the prison population in Scotland, there's very high rates of having had a head injury, which can make the diagnosis of ADHD more challenging. The other thing that's practically important is that we've done general adult ADHD clinics in general adult psychiatry. I know how useful it can be to have someone's spouse coming along or someone's mother, and in the custody environment usually you're seeing the individuals on their own, and it can be very difficult to find someone to contact. A lot of these individuals will have had quite a disruptive upbringing, and trying to find someone who is able to give a collateral history or a history of symptoms in childhood can be difficult. The other thing that I've noticed working within prisons and looking at ADHD is that actually I think the prison regime and routine can sometimes mask symptoms. If you think about the things that are helpful to people with ADHD, it's sort of establishing routines. Well, the prison gives you a routine. There's a set time you have to get up. There's set things you have to do during the day. There are also, unless you choose, there aren't significant challenges that you have to engage in unless you are particularly motivated. So you don't have to go to school, so you can just sit in your cell if you wish to do so. Also, you don't have keys, you don't have phones to lose, so you don't have to organise yourself in the same way. So you might not see that same functional impairment at a time when the person's in custody. That may, of course, be a very different story on release, when someone goes back to living out with custody, and that's where really some of the chaos can return. The next set of challenges are really around the treatment. For using controlled medications, which are of course methylphenidate and its long-acting versions would be first line for prescription, and if these are to be administered within the prison environment, they need 2 nurses to issue them or dispense them. And the other thing is, in a lot of prisons, patients will have what's called medication in their possession. Well, they'll be given a week's supply of the medication into their cell, to take as they need. And that works quite well for antidepressants, say for example mirtazapine that you want to take at night, etc., and gives patients autonomy over taking their medication. But with the controlled medications, that's not possible within prison. You would never give a prisoner controlled medication into their cell. You would have to witness them taking it. We'd also note there's quite a limited availability of psychological therapies, so thinking about that pills and skills bit, often there's limited opportunity to really give them the support with the skills building. Compliance can be an issue within custody, and one of the big things is that for taking a stimulant medication, people that were prescribed it may have had experience of patients telling them that when they take it, it can be quite an intense feeling. It can make them feel quite suddenly alert, which they're not used to. And when you're not engaged in it, that's all very well, you know, when you're trying to do some reading or you've got something that you really want to focus on and do. But when you're kind of sitting in your cell, it's often described as quite an unpleasant feeling. So a lot of the individuals don't like being prescribed medication when they're not actively engaged in any activity. One of the other things we found in this group is that for a lot of people who've grown up with ADHD, and there can be some of the symptoms can be really quite important to their identity, in terms of how others see them, you know, in being that kind of impulsive individual who's got lots of bubbly energy. And when they're not that individual, a lot of people can struggle with that change in identity and not actually like the way that it alters them. So we have had people who didn't want to take medication, although they found, yeah, they could concentrate better, but actually, you know, they didn't like that change to them. That can be one of the other things you find. The last thing I'm going to touch upon is a trial that's recently been completed, and this was an NIHR funded double-blinded randomised control study of Concerta XL in adult offenders, headed up by Professor Acheson down at King's College London and Professor Lindsay Thompson at the University of Edinburgh that I worked on, and it was aimed really to do two things: to see would this medication be helpful in young offenders in reducing their symptoms, and secondly, would it have any effect within the prison environment on some of the functional difficulties, so around emotional dysregulation, antisocial attitudes and behaviour, violent attitudes, and the number of things they were able to engage positively in within the prison. So it was an 8-week double-blinded randomised controlled study, looking at young male prisoners aged between 16 and 25 who met DSM-5 criteria for ADHD. And they were across 2 sites, which is ISIS in London and Polmont. And then at the end of the project, we offered all individuals who'd taken part the opportunity to take ADHD medication. So that recruitment target was met in spring 2019, and that report is currently being finalised and will be published shortly. And so the research team have now left HMYY Polmont, but created a kind of SBAR documentation which has been shared quite widely across the SPS and NHS services, really highlighting the issue of high levels of ADHD symptomatology within the prison population, and thinking about how we attempt to help these individuals going forward and some of the benefits and challenges to that. Thank you very much for listening.
Okay, thank you very much for that, Sheila. Our last presentation is delivered by Prem Shah. Prem has been a consultant psychiatrist in Lothian for many years and has worked in the area of adult ADHD for some time there. In addition, more recently, he's got some sessional input to the National Autism Implementation Team. So Prem is going to talk about adult ADHD in the digital age, which is very topical just now.
Thank you very much, Marie. My first slide just gives you a list of my affiliations. And as Marie said, it is actually quite opportune that we're talking about ADHD assessment in the digital age. I think the starting point is probably March 2020, when the world, for many people, including us clinicians, changed quite substantially. As of immediate effect, all elective psychiatric assessments were suspended and IT went into overdrive to build up capacity to allow, amongst other things, remote consultations. But I would suggest that there's actually been a much wider impact, both in terms of the medium as well as the long term, in terms of potentially changing and re-evaluating normal clinical practice. In actual fact, it could turn out to be an opportunity to go and practice clinical psychiatry more efficiently in some circumstances. So just to recap from what has been said before, why should we actually assess for ADHD in adult practice? And mainly the headline is it's really common. ADHD is a risk factor for both episodic and trait disorders in psychiatry. And interestingly, 70% of those who are eventually diagnosed as ADHD have previously received treatments for other psychiatric conditions, and that too often unsuccessfully. And as has been said before, identifying and managing ADHD can actually change treatment trajectories and expectations. And also, just to go and hammer in the message, it is not as if the scenarios where ADHD may be present are uncommon. Here is a list of the sorts of scenarios where you might think ADHD is present. And I'm sure you'd agree that these are common scenarios in everyday adult practice. So I'm going to talk about the assessment process, which is one of the major things that we do as psychiatrists together with our teams. And the assessment process, before moving on to the digital bit, the two components that are required are both a full psychiatric history and a neurodevelopmental history. It's not an emergency, which would make some people think that it's not a priority. However, for the reasons already stated, we would argue that people should be armed with the ability to go and assess for ADHD and manage it. And again, just top line messages, assessment takes time. Because you're assessing traits, you require a lot of information. And again, to go and emphasize that diagnosis is very much based on clinical judgment, preferably using the skills and views of a multidisciplinary team. And also importantly, triangulating our information from a range of sources. Of all the things that are really important, it's the idea of functional impairment. Because these are traits, it is entirely possible for people to have a lot of these traits, but not necessarily to be functionally impaired. And that is important in the whole assessment process. So let's look at the assessment process itself and think about how could this be delivered without necessarily seeing the patient at all stages. Primarily because COVID has been in the mix, but also going forward in terms of time efficiency. So when you look at this diagram, you could start to see that there's some elements that could be delivered without having to see the patients. So for example, screening, collecting a developmental history, but there are some elements which require contact with the patient. If we look at the screening information, and here I'm going to refer to the experience that we've had in NHS Lothian, which has been doing this for a while and would hopefully go and inform my colleagues in other parts of the country. And what we have found is that screening information can be gathered without face-to-face contact. What we do locally is we use the ASRS and WIRS, which you've just heard about in previous talks. And importantly, we use the WHODAS, the World Health Organization Disability Scale, where we need as a threshold to have a person having moderate impairment in 2 out of 6 domains. We also include the early development questionnaire as part of the screening information. And using that combination, what we find is that 10% of referrals do not actually have significant functional impairment, although they may screen positive in terms of ASRS and WIRS, and therefore do not require a further in-depth clinical assessment. And this can actually be done without needing to see the patient. Concentrating on the developmental history, which we all have a knowledge of from our previous training, but is rarely taken as a general adult psychiatrist, this factual information can actually be gathered, again, at least an outline, by using a questionnaire. And there are a number of questionnaires out there. We've devised our own in Lothian, and having used it, we actually find it really very useful in terms of identifying people who may have neurodevelopmental issues. And the sort of areas covered are indicated above, so they can be very factual. If the person gets past that screening process, we then need to think about the psychiatric assessment, the actual bit where we might want to see the person. And there are 3 components of information that we want. One from the patient, secondly from third party or corroborative information, and thirdly, the third component is actually observing the patient in terms of their behaviours, their emotional reactions. Each of these components is important in terms of coming to our clinical judgment. So it's no different compared to how we assess people for other mental problems, except that a volume of information is much more extensive and there is more weight put upon third-party information. Now, when you think about how we normally do it, we've always done it on a face-to-face basis. We see the patient in clinic, we will go and invite the patient to provide other information or to provide a relative who may be able to provide corroborative information. So if we then divide up what it is we do in the face-to-face and think about, can the remote access technology provide that? And I'm dividing it arbitrarily between video consultation and phone consultation, then I hope it kind of clarifies what can and cannot be done. And I've just put this up on the basis of my personal experience, but also the experience of my other colleagues, both locally and nationally, in terms of neurodevelopmental assessment. There is a key question, which is why see someone? Because private assessments in psychiatry and psychology are already being carried out by video, and within the NHS, assessments are already being carried out even before COVID in remote areas like the Highlands. So if we kind of just roughly divide up what we're trying to gain from patient contact, well, there's the aspect of factual information, which any of the mediums could actually lend themselves. Where it starts to become a bit more challenging is in the more subtle aspects. So assessing cognition and mental state, we would regard face-to-face as being gold standard, but video is actually not bad if the differences or the changes are obvious. Similarly, in terms of assessing the person's emotional reactions, their social behaviour. Video is good if the differences are obvious. And also in terms of not only gathering information from a third party, but seeing their responses. Again, if they're obvious, video is actually quite a good medium. And in that sense, the phone, gathering information purely by phone is insufficient. It goes without saying really that we cannot really go and cover physical examination with remote assessments. So from the bit of personal experience and also experience from others, the summary is that ADHD assessment is possible using digital technology. Rather like your everyday assessment, getting information beforehand is actually critical. So the main task of assessment is not just seeing the patient, it is actually assimilating all the information which is available. And importantly, about 50% of people who are looking for ADHD assessment have had mental health contact before. So a lot of information can actually be gleaned from case notes beforehand. And then we would recommend a video consultation as being the main way forward, being aware that in situations which are more subtle or more complex, that a face-to-face consultation may be required. In the longer term, there are actually advantages to the video consultations. It can be really quite time efficient and convenient for everyone concerned. You can actually get a little peek into that person's home environment. So even though the person may say that they're reasonably organized, when you look at the environment, you can actually see that it isn't. And obviously it is COVID safe. There are disadvantages to video consultations, obviously, with technological glitches coming in the way, not necessarily being able to pick up subtle features. And we have to remember that there aren't any robust studies comparing the validity of video consultation versus face-to-face consultation. More broadly, you might wish to consider a number of factors if you're considering a remote assessment, and you could divide it up into these different categories. First and foremost, there could be individual preference. Specifically, the patient may actually want to see the clinician. And then there are practical considerations, such as if you require an interpreter, or if the person has a disability that limits use of phone or video equipment. And obviously, there are limitations in terms of technology. The other thing to consider are a whole range of clinical factors, such as that the person might have a difficult environment for whatever reason at home, and they may not want a video consultation there. And then you get into where there are subtle, complex presentations or discrepancies in the information that you get. And there you might have to look at having a face-to-face consultation. Also, it does depend on how confident people are, clinicians and patients, in terms of remote assessment. And it goes really without saying that if an individual presents with a lot of distress or has significant clinical risk, that you would be looking at a face-to-face assessment. Although the scenario that I'm thinking about is more the cold planned assessments where you shouldn't hopefully have significant clinical risk. Again, more broadly, when you think about communications in the virtual world, I think for most practitioners, Near Me is available. And certainly we're being encouraged to use virtual platforms, Near Me being the one of choice when it comes to interviewing patients and families, and Microsoft Teams being encouraged to be used as we are here when we're collaborating with other professionals. You'll probably know that Near Me does have the capacity to have more than 2 people attending an appointment, but patients can join a Teams meeting where it is more than Near Me would allow, but this does require an additional license, and we would suggest that you go and discuss such a scenario with your local IT team to ensure that the right policies are in place. And then just a short note about confidential information being exchanged, particularly from out with NHS boards. It's just a reminder to say that it can be done as long as you've got a data sharing agreement between the NHS board and, say, for example, social work. You need to confirm that there is data sharing agreements in place, and if not, please do not communicate that information. You will run into trouble. You need to ask your line manager in the IT department about how communication could be transmitted. Finally, I wanted to go and pardon me, make you aware of 2 potential resources. One being the National Autism Implementation Team, which also addresses ADHD. It has a document which goes into digital consultation in much greater depth. And secondly, to go and advertise the Lothian Adult ADHD and ASD resource team, we may not be able to provide direct clinical input, but we could certainly provide advice in all aspects of ADHD and ASD. And there's the email address for your use. Thank you very much, and that's the end.
Okay, thanks very much, Prem. So thank you everyone for listening. I hope you found that useful, and we really hope to hear more from you over the next weeks to months as we go around each health board engaging with the feasibility studies. So the more the merrier really, and you're all most welcome to join. Okay, thank you.